So what I'm going to talk to you about is, first of all, the nature of coarctation, emphasize again the role of the arterial duct, and then eventually emphasize once more the importance of the associated malformations linking together coarctation and interruption. So when we come to describe coarctation, we need to separate the various entities that can produce obstruction within the aortic arch. And these are the formation of a shelf, as opposed to a waist lesion, where the walls are simply folded in to produce the obstruction. But perhaps most worrying is the presence of tubular hypoplasia, as pictures speak much better than words. So here is what we mean by the waist lesion. And here is a nice example of a waist lesion, and you see that the walls are marginally thickened at the union of the isthmus with the arterial duct, but only marginally thickened. And the major problem is that the union between isthmus and duct has been pinched in on either side, so we have the obvious formation of a waist. And as you see, that typically is found when the arch itself is patent. And we distinguish that from the shelf lesion, and the shelf lesion most typically is found when the arterial duct has become ligamentous. And then this is the type of lesion that we see much more typically in older patients with aortic coarctation. And indeed, even in the best regulated households, some of these patients survive till the age of 20 or 30 or even 40 with this lesion before it's picked up. And another anecdote, my wife's cousin had seen the very best physicians in the United Kingdom and South Africa, and visited us in Pittsburgh complaining about hypertension, and he was seen by my very good friend and colleague Bob Zuberbuehler, who diagnosed his aortic coarctation when he was 35 years of age simply by comparing his femoral pulse and his radial pulse. And I'm pleased to say he then came over to the Brompton Hospital while I was still there, and Christopher Lincoln did a wonderful repair, and he's now continuing to go strong. So this is the type of lesion that you see in adults with coarctation, although hopefully much more rarely in this day and age. This, on the other hand, is the type of lesion you see in the very young patient with coarctation. And this is tubular hypoplasia of the segment of aorta between the left common carotid artery and the left subclavian artery. The left subclavian artery itself is very small. Andrew has shown you examples of this, and almost certainly this left subclavian artery is caught up within ductal tissue, but over and above that here we have an extensive area of tubular hypoplasia of the aortic arch. And of course, flow to the descending aorta now is upon the arterial duct. And it is relative to the arterial duct that we describe the various forms of coarctation. And in my experience, the greater majority of coarctation, certainly the ones we see in the autopsy room, are found in pre-ductal position. So the duct is feeding directly into the descending aorta. There are a proportion of cases, however, that are paraductal, and I've shown you an example of paraductal coarctation in the setting of hypoplastic left heart syndrome. And then the ductal shelf, or rather the posterior shelf, divides the stream along the duct into one pathway going to the descending aorta, another pathway going to the ascending aorta. And then, exceedingly rarely in my experience, but much more frequent in clinical practice, is to find the situation where the waist or the shelf is in post-ductal position, so the duct is pointing into the ascending component of the aorta. Now, key to all of this is the role of the arterial duct. And for a long time it was doubted that the arterial duct had any part to play in aortic coarctation. And this was despite the fact that in a particularly elegant paper in 1969, Wielenka and Dankmeyer from Leiden University had unequivocally shown the importance of the arterial duct, and this had been emphasized by their surgeon, Gerard Brom, who wrote a wonderful paper called Narrowing of the Aorta and Widening of the Mind. It was a particularly important paper that I still recommend to you. And Jerry emphasized that the shelf lesion initially was composed of ductal tissue. This had been denied by Rudolph and his colleagues in San Francisco, who argued that all depended on flow, but in fact that is not the case. And it's important to recognize this because now we know that that shelf lesion is arguably not suitable for dilation because the obstruction will recur. And so the situation, as shown by Wielenka and Dankmeyer, was to point out that there was a marked difference in the normal situation, where, as you see, the ductal tissue shown in yellow does not extend to surround the entirety of the aortic arch. So there is an unimpeded pathway from the ascending to the descending part of the aorta that is not encroached upon by ductal tissue. Whereas what Wielenka and Dankmeyer showed, and this was confirmed by Yen Ho, working in my laboratory at the Brompton Hospital, was that in the presence of coarctation, the ductal tissue lassoed the junction between the isthmus and the descending aorta, and indeed it was ductal tissue that formed the posterior shelf. And now this is indeed the case. We can now move on, and we can move to interruption of the aortic arch, which is an endpoint of a spectrum of malformation, certainly when it is found at the aortic isthmus. It's probably also the endpoint of tubular hypoplasia in the other components of the aortic arch, and as Andrew has shown you, in fetal cases you can almost see the spectrum developing. And the importance of interruption is first, where within the arch does the interruption occur? Second, what are the specific ventricular arterial connections? Because we can find interrupted arch with concordant connections, discordant, double outlet, and as you have also seen, with common arterial trunk. But perhaps most importantly, associated malformations. Now, when we describe interruption of the aortic arch, again, we find ourselves using an alphabetic categorization, first introduced by Soloria and Patton. And they describe three types: interruption at the isthmus. So the arch is divided between the descending aorta and the left subclavian artery, and then the duct feeds the descending aorta, and this is so-called A. There is then type B, where the interruption occurs between the left common carotid and left subclavian arteries. And then the duct feeds descending aorta and left subclavian artery. And this is the pattern that is most frequently found in 22q11 deletion. And then the rarest type is so-called type C. For a long time it was doubted whether type C truly existed. I've never seen a case myself, but Dr. Ho has a case in the archive of the Royal Brompton. And in type C, the interruption is between the carotid arteries. But a potential problem can arise here when you have retroesophageal origin of the right common carotid artery, and then the V formation you see in the aorta there seems to be replicated by the two common carotid arteries themselves. But despite those caveats, Dr. Ho's case unequivocally does have interruption between the carotid arteries, so it really does exist. But as I say, the most important feature is the associated lesions. And this aphorism, "all the woe lies below," is one of the splendid sayings of Richard van Praag, and in this instance it is absolutely true, because whenever we find interruption or indeed severe coarctation, we should look for lesions within the heart that have reduced aortic flow during fetal life. And those lesions can be a ventricular septal defect, restriction of the infundibulum, and that is typically seen in the Taussig-Bing malformation, or a restrictive ventricular septal defect when there is univentricular atrioventricular connection to a dominant left ventricle. And we saw that this morning in the setting of both double inlet left ventricle and tricuspid atresia. And remember, the other associated lesion, nothing to do with the woe lying below, but retroesophageal origin of the subclavian arteries. So the final two sections I'm going to show you, parasternal long axis equivalents, which show the typical ventricular septal defect associated with interruption of the aortic arch. And as you see, what is happening here is that there is posterior deviation of the muscular outlet septum into the left ventricle, and that has reduced the flow up the ascending aorta and has been associated with interruption of the aortic arch. But beware always expecting posterior deviation of the muscular outlet septum, because you can get exactly the same thing as you see in my second specimen, where it is deviation posteriorly of a fibrous raphe, when the defect is doubly committed and juxta-arterial, again with narrowing of the aorta, and again with interruption of the aortic arch.